Exercise considerations for persons with neurological disability. So before I get started, I want to talk a little bit about this presentation. This comes from some work that I've developed over the past few years at Mount St. Mary's as part of their doctoral physical therapy program. And I always have to pay tribute to my mentor, Dr. Jacqueline Perry, who influenced a large group of clinicians who walk away with the thought of strength is good. So basically, this is going to be the theme of my talk. And what the theme is to consider that when patients get stronger, typically, for the most part, they function better. So we think about functional training and task specificity when we talk about the neuro population, but if we also think about getting them stronger, typically they tend to do better. Not always, but often. So the first half of this talk is really going to talk about the consequences of disability, some general recommendations, and then how do we promote physical activity in people living with disabilities. So if we look at people living with disabilities, they actually report poor health more often than people who do not have a disability. So 37% of people living with disability report poor health compared to just 8% of those who are living without a disability. And if we look further, adults with disability are 3 times the consequence of this. It's that adults with disability are 3 times more likely to have secondary complications like heart disease, stroke, diabetes, or cancer. And nearly half of the adults with disability get no aerobic physical activity. And I think at this point in your personal life and professional life, you probably recognize the benefit of aerobic activity. So I'm going to talk about some basic recommendations for resistance training and aerobic or physical activity. So resistance training, to start with recommendations, we look to the healthy population. So when I use my recommendations for resistance training, I always refer to the American College of Sports Medicine position stand that they published in 2009. And before we even start thinking about what the recommendations are, we really have to be clear about what our goals are, and then how do we design our program to meet those goals. So most of what we're going to talk about is strength, which is the maximum amount of force a muscle can exert against resistance for one single effort. But we also do have to consider occasionally muscle power or muscle endurance, and we would tailor our exercise program, our resistance training program, to achieve these various goals. So when we talk about people with neurological disability, we're going to categorize them into this novice or untrained category. So when we recommend resistance training for people with disability, we think of asking them to perform 8 to 12 repetition maximum. So the amount of resistance that they can tolerate before they either can't perform the exercise or really see a significant degradation in form. So if they can do an exercise and do 20 reps without getting tired, you need to change the load. If they can only do 2 reps before they start compensating, you need to change the load. This is how we typically measure things clinically, is through this repetition maximum. The classic way is to measure what can they do maximum load for 1 repetition and then take a percentage of it. But the equivalent is to do an 8 to 12 repetition maximum. And then we will like to see increasing in load every time they can perform 2 reps above the goal for 2 consecutive sessions. That's when you're going to start to see a requirement to increase your load. In addition, we want to see our repetitions be performed at a slow to moderate contraction speed, and we really only need 1 set to get a benefit. If we do more sets, we do get additional benefits, but you don't see a significant benefit until you get up to your 4th set. For somebody who is starting, the biggest bang for their buck comes with that 1 set. And then we need to see these exercises being performed a minimum of 2 to 3 days per week. Also, we want to recommend that we're exercising 8 to 10 major muscle groups. We want to perform our exercises through the full range of motion in a controlled manner. And one of the interesting recommendations is that exercising with a training partner improves your progress. So it improves your adherence to the training program, your motivation, and also how much you actually benefit from a resistance training program. If you want to train somebody for muscle power, you're going to take the same training principles of strengthening, and then you're going to add some extra activities. So you're going to do more light weights, lighter loads with faster velocity contractions. And then you're going to be, with the power training, you're going to be doing more sets with fewer with small rest periods between the sets. And for power, you want to emphasize multi-joint exercises, especially those involving total body. Again, a lot of what we do with the neural population, we really don't train for power just because it's challenging. Although this is something that could be really beneficial to our patients, it's hard to execute this in clinical practice. So a lot of what we'll be doing in clinical practice will be recommendations for strength training or muscle endurance training. So the final consideration for resistance training is endurance training. And with these, the ACSM guidelines are to use light to moderate loads with higher repetitions. So more than 15. So clinically, I usually do between 15 and 25. If they do more than 25, I start to think about increasing the resistance. And then again, shorter periods of rest between additional sets or additional exercises. When we put somebody on a resistance training program, we are going to see changes in the muscle, so increased cross-sectional area. We'll see increased size, number of myofibrils. We'll see satellite proliferation, hyperplasia. We'll see changes in the muscle fiber type and architecture as well. Additionally, we're going to see some neurological adaptations that are going to make that muscle perform better for different tasks. So resistance training actually trains both the muscle and the nervous system. So we're going to see improved intramuscular coordination. You're going to see adaptations between the agonist-antagonist muscles. And then for the muscle that's active, you're going to see an increased firing rate. So you're going to see this better efficiency of a muscle activity. And clinically, this is sort of the classic paradigm of what we think about with a resistance training. So if you take somebody who's starting a resistance training, the blue line shows that in the early weeks, you see strength gains, and then eventually those strength gains can start to plateau over time. In the very early stages, this is a mixture of neural adaptation and muscle growth or hypertrophy. Again, if we look at that very early stages, so then again, think of somebody who's had a stroke. This is where we're working with them. We are really trying to maximize this change in neural adaptation. So we're trying to improve the ability to recruit muscles through our strengthening programs. It's not until we get later on into these strengthening programs that we actually start to see adaptations in the muscle itself, the morphology of the muscle morphology. So early in these programs, we really have to think about how can we maximize this phenomena of strength benefits being the result of changes in neural activation. Okay, so in addition to resistance training, we want to think about physical activity or aerobic activity. And we all know regular physical activity reduces the risk of many adverse health outcomes. The more activity you get, the more benefits you get. And in converse, some activity is better than none. So if you're doing nothing, doing something is better than doing nothing. The health benefits related to physical activity do occur similarly occur for people with disabilities. And these benefits far outweigh any possible adverse effects that could potentially happen from participating in a physical activity program. So if we look at the guidelines for physical activity, the minimum recommendation for healthy adults, for adults living in the community, we basically say the minimum recommendation is at least 150 minutes per week of moderate intensity physical activity. Moderate intensity is something that we usually say is it's sort of your heart rate gets up, you're starting to sweat, you can still talk during the activity. So if you're exercising at a point where it's difficult to carry a conversation on, you're probably beyond what would be considered moderate intensity. Alternately, the recommendations would suggest 75 minutes of vigorous activity. So this is going on a jog on the treadmill at a relatively high pace where you're sweating hard, you're breathing heavy. The alternate to these two recommendations is a combination of the two. So I could do 100 minutes of moderate intensity, and I could do 40 minutes of vigorous activity, and that combined meets these minimum recommendations. You should also consider combining both aerobic and muscle strengthening because both are beneficial. Aerobic activity has to be performed in episodes of at least 10 minutes. And that's the key here for physical activity, because I think people often think, oh, I don't have time to go to the gym, or I don't have time for this, or I can't exercise for more than a period of time. So if they can do this moderate intensity activity for 10 minutes, that counts towards these minimal recommendations. If we look at what the recommendations for people with disability, they're exactly the same. So we don't change any of the recommendations. They're exactly the same because the health benefits are going to be related to the activity, not the disability. Same thing, both aerobic and resistance training. Episodes need to last, aerobic activity needs to last episodes at least 10 minutes in duration. And then the recommendations for people with disability is to perform strengthening activities at moderate to high intensity and to work all major muscle groups 2 or more days per week. And that's very similar to what the ACSM guideline is for a novice or untrained healthy adult. And then the key difference in this in these guidelines, this is available at US health.gov, the PA guidelines, physical activity guidelines. The key recommendation that comes out that stands out, what makes it unique about this recommendation for people with disability is that when they can't meet the recommended guidelines, the recommendations state engage in regular activity to your ability, avoid inactivity, and then consult healthcare providers about the type and amount of physical activity you should be performing. So that's the only thing that's different between somebody who's disabled and somebody who's not. The recommendations are exactly the same. So how do we promote physical activity in our patients with neurological disabilities? And I think for me, this slide sort of represents all the different hats that I would wear. I could be the coach, I could be the cheerleader, I could be the motivational speaker, or I could be sort of that dogmatic, preacher who says, thou must exercise. So depending on the patient, depending on the situation, I can kind of morph into any one of these caricatures and say, this is how I'm going to approach promoting physical activity for people with neurological, with disability in general. CDC provides, and this will be part of a reference list, the CDC provides some nice recommendations on how to approach it. The key thing that I learned from this website is that people living with disabilities are 82% more likely to be physically active if it's recommended by their doctor. Now, I think I could substitute by their doctor of physical therapy, and that would be just as likely a statistic. So the CDC sort of runs you through this map of knowing what the guidelines are, and we just sort of covered that very briefly. They say ask about their physical activity. I say screen for exercise readiness, because we've got to make sure that the patient, somebody with a neurological disability, we got to make sure they're actually capable of exercising. We definitely need to discuss barriers, and then we want to provide recommendations and resources to these patients so that they can actually be successful. So we need to kind of remove barriers and promote activity. So for me, this is where what I do, talk to the patient, talk to the doctor, because if there is a need to talk to the doctor, and oftentimes there's not. And then there are two PAR-Q and PAR-Q Plus. It's Physical Activity Readiness Questionnaire, and the reference comes in the next slide. So what that those references do, they really kind of help you identify when is it okay for a patient to do things on their own and when do they need help. So for somebody with stroke, I'm going to take you through this table. On the far right-hand column under supervision, QEP stands for Qualified Exercise Professional. So that's you and me. All right. So if we look at that first row, which is the third one down, where QEP directed comes in, anytime the risk level is to having an adverse event from exercise is intermediate, or anytime the activity level is moderate, this should be directed by an exercise. These programs should be directed by an exercise professional. And for somebody with stroke, the biggest risk is recurrent stroke. So that has to do with their blood pressure management, their age, their time since stroke, their meds, all those kind of things will determine their risk level. So anytime it gets to be an intermediate risk level or a moderate level activity, which is what we're recommending, it should be supervised by an exercise professional. If we look at the risk assessment from these articles, if we look at the risk assessment for somebody with spinal cord injury, it's very different. So I can go down all the way down to an intermediate risk level and a very hard effort before it needs to be supervised. So if I have someone with spinal cord injury, I could just say, here's your exercise program, go do it. In most cases, it's only when it starts to get a very high level of effort or their risk level is greater than somebody with a typical spinal cord injury. So risk for DVT, risk for fractures from osteoporosis with exercise. The big risk is autonomic dysreflexia. So that your higher level spinal cord injuries are at risk for autonomic dysreflexia. Those are the types of patient situations where you have to be really acutely aware of, I need to supervise them before I set them out on their own. Okay, so if we talk about the next thing we want to talk about is barriers to exercise. And I look at this poor gentleman in the gym and I think, I don't need one more obstacle to do an exercise, and this guy has it. So what do we have to think about with barriers for people with physical disability? So for me, the way I always kind of frame things is I put it within the ICF framework. And if we look at personal factors and environmental factors, we can have some barriers that list in here. And I just created a couple of things that I think of as barriers under the personal factors barriers. So number one, they're so disabled they can't exercise. Number two, their cardiovascular capacity is so poor they can't perform exercise. Just like you and me, motivation and adherence is a huge barrier to exercise. It's greater for people with disabilities. And then the last one is really the critical piece, is knowledge of how to implement these programs or knowledge of what the community resources are. So community resources and how to implement these programs, that's sort of where we come into working with our patients. We can very much influence how they exercise. If we look at environmental barriers, access to adaptive equipment, access to the environment, cost is always a barrier to exercise. For people with disability, it becomes more of a factor because they have shift in their finance more towards medical than if they were not disabled. So they may have the ability to afford an exercise membership before their disability. After their disability, they may not be able to. Transportation, and then societal barriers. So society often depends on where they are, still looks at people with disabilities as not somebody who should be out there exercising. And these are all things that people with disabilities will have to overcome. Okay, so when I approach my patient, I always, again, I'm going to put it in my clinical judgment. I'm going to bring out the best evidence, and I'm going to think about that patient perspective. And when it comes to exercise, therapeutic exercise, and physical activity, resistance training, aerobic training, I always want to know three things. I always want to know, what is their prior exercise experience? I want to know what's their exercise preference. Do they like going to the gym? Do they like the latest and greatest? Or do they just like getting out and playing? It's more recreational activities. Maybe they like to get their exercise through gardening or hiking or walks on the beach. And then what is their preferred exercise setting? So do they want to come into a clinic? A lot of patients don't. Do they want to do it in their home? Do they want to do it in a community or an adaptive fitness center? Or do they want to be outside playing basketball with their friends and families? So these are sort of the things when I look at how am I going to assess this, bring this patient perspective into the mix in planning my exercise program for patients that I'm working with.